questions.
All right, thank you, Anusha. Are there any questions? I see that Dr. Rosen has his hand up.
Anusha, what do you think the value of passive descent of the head in a case like this is? Do you agree with that maneuver of, okay, the tracing looks meh, and I'm going to let, and for whatever reason, give the patient an hour of rest before we ask her to push again? Was she exhausted? Was that the reason why? Why did we make that decision?
Yeah, in this case, it was from maternal exhaustion from pushing. I know that there are some thoughts of, laboring down versus not, but studies have found that laboring down just increases the time to delivery and risks of increased blood loss. So generally, I would say once they're fully dilated, starting to push and is the best mode to get to delivery.
Did you just say that laboring down is not productive?
Yeah, like just waiting for the head to come down.
Yeah, and Dr. Ebert, I would add to what Anusha said that increases in chorioamnionitis as well. There's more infection when you let somebody labor down instead of pushing. The other question I wanted to make is that, if somebody's making adequate cervical change, even if they don't have 200 Montevideo units, I think that's unimportant. They've proven that their contractions are adequate to get them to 9 or fully dilated. I don't think giving them a lot of extra pit at that point is probably all that useful, or relying on your IUPC to help guide your labor is that important. She's already proven her contractions are sufficient, and you'll see what she does next. I don't think you need, like, a patient's contracting every 2 minutes is made it to 9.5 centimeters. I don't think you need to keep going up on the pit. I think you're just increasing the odds of creating harm by doing that.
I see that Dr. Singla has her hand up.
Hi, Anusha. Thank you for the presentation. So I have a question. So what was the mention about how impacted the head was, and where was the vacuum placed? Did they mention the placement, where exactly it was placed? That's number one question. And the other question is, what other maneuvers you can do to relieve the deeply impacted head that will decrease the blood loss, that will also decrease the incidence of extension of uterine incision?
Yeah, so in terms of the vacuum and how impacted the head was, it wasn't noted that a hand from below was required, but for the placement of the vacuum, it was placed twice. The exact positioning was not noted, but if the head is very impacted, other maneuvers besides hand from below, you could also try to deliver the fetus breech extraction through the hysterotomy, so a reverse delivery breech.
Hey, just to add to that, there's a new device that's on the market called the obstetrical pillow. Do they have that where this patient was delivered, Anusha?
No, they don't.
So
but I have heard of that.
Yeah, it's a balloon. It's a balloon you blow up in the vagina, you inflate it, and that gently lifts the head out of the pelvis. I'm not sure how if it's really all that helpful, but it's another technique that a lot of hospitals, it's another device that a bunch of hospitals have bought to help with these kind of things. The vacuum is not helping with your impacted head, right? That's once it's out, you can't deliver through the incision, you put the vacuum on.
Yeah.
But whatever.
All right, well, thank you, Anusha, very much. Excellent job. And thank you for going first, presenting in person. Much appreciated. So in just a minute, I'm going to ask Dr. Matthews to introduce our grand round speaker. But before that, with regard to attendance, we'll be taking attendance using the participants list at 8:10. So if your name is listed clearly, or if I see you here in MEB 102, then you'll get full credit for attendance. And the CME code will be distributed by the email system. And with that, Dr. Matthews, are you ready to introduce our speaker?
I am. It's my pleasure to introduce Dr. Lauren Owens. Dr. Lauren and I completed fellowship in the same cohort. She completed fellowship at Michigan. She is currently an associate professor at University of Washington, where her research is focused in reproductive health and trauma trauma-centered care. She's presented the trauma-informed care presentation at a couple of really well places. She did this at ACOG, and we were very excited about her presentation and wanted to bring it to our department. I'm excited. Lauren has had several publications with trauma-informed care within the last couple of years. So Lauren, I welcome you to our Department of OBGYN.
Thank you so much, Dr. Matthews. It is great to see your face. I have to say, I'm very new to WebEx, although I'm really grateful for the orientation I got. Can you see my face? I tried to put the camera on thing, but I don't know if I need to pause sharing to do it.
No, I don't see your face.
Okay.
We see your slide perfectly, though.
Okay, let me stop for a second and do this. How's that?
Yes, we
Yes,
see you
we see
now.
I
both.
think that worked. Okay, thanks for your patience with me. Thank you all so much for having me this morning, although virtually. I'm really glad to be here with you talking about trauma-informed care and how you can incorporate it into your practices. I think especially having heard your really well-presented cases from your morbidity and mortality conference, I think it's a really great time to talk about this because I think, as we'll discuss, all of us as clinicians experience potential trauma in our work, all of these really intense cases that we go through. So it was great to be able to listen to some of those presentations, and thank you for allowing that for me. I don't have any financial disclosures related to this topic. And then my goals for us are that after we're done spending time together today, that folks can really describe how prevalent trauma is and what it can do to folks' health, talk about what the principles of trauma-informed care are, and personally think about your own practices and identify at least 3 ways that you can integrate trauma-informed care into your practice. So I want to say many of us have trauma, whether it's work-related trauma or other kinds of trauma we've experienced in our lives. And so I want to really encourage people to just be careful for yourself during this time. If you need to turn your camera off or take a break or kind of just check out from the session, whatever makes sense for you to be protective. As we'll discuss in the session, we really can't provide trauma-informed care for others without caring for ourselves. Okay, so speaking of WebEx challenges, we'll see how this goes. If it's possible, I'm going to stop sharing slides and activate this poll. I'm a little worried that all 3 of them are going to show up at the same time, but let's see how it goes. So for those of you who are on the platform right now, you might be able to see this and respond. Looks like one person is working on it. So the question is kind of what was your first time getting didactics or training on trauma-informed care? Maybe within your training as a first option or learning on your own. Maybe you did some CME on it and maybe today is the first time for you. So there's a couple people responding and I recognize that I think it's great that you're having your in-person. I don't know if that limits people's ability to reply. So I might be skewed towards people who are virtual. But I do see that all 3 of the questions that I had kind of open. So we'll just give it a minute and then take a look. And then it sounds like there's also a hand raising function. Is there a chat function that people could use to drop in like an ABCD? If that's the case, I can read the options again. So A is within your own training or education. B is learning on your own during practice. C is CME, and then D is today. So if you want to drop a letter in the chat too, you can do that. And we'll give that 1 more minute and then we'll close it. Okay, so it looks like I've got a decent number of respondents here. We'll go ahead and close the poll. And I'm guessing this may pop up the results for you. So of the folks who are here, about 60% weren't able to answer virtually, but among people who did, of the, let's see, 18 respondents who responded, 10 got training on this during their own training, which is amazing. That's great. 1 had learning while in practice, 2 had CME, and then 5 are having their first interaction on trauma-informed care today. And then thanks to Miriam for responding in the chat that you also had some training in practice. That's great. Okay. So as we think about trauma and what it entails, this is a great document from SAMHSA that I would highly encourage anybody to read. It's a pretty quick read and has some memorable parts like kind of conceptualizing trauma through 3 E's. So, trauma is harm that impacts an individual's functioning and their well-being, and we can really conceptualize it through thinking about the first E, the event or events that happen to a person or people. And different folks have different experiences of the same event and also can have different sequelae or effects from that kind of traumatic event. So trauma means that somebody has experienced physical or emotional harm that has lasting adverse effects for them. Now, not everybody who experiences trauma or something traumatic develops PTSD. So some of the hallmarks of PTSD are going to be intrusive symptoms, things related to avoidance or mood or arousal dysregulation. Somebody with PTSD could be having nightmares or flashbacks, hypervigilance or dissociation, detachment from others. And really both trauma and PTSD have health impacts that merit further attention. So when we think about trauma and one aspect of that, thinking about childhood sexual abuse, ACOG has a great opinion about this, a committee opinion, but a significant percent of children in our country experience this. About 1 in 5 cis women have experienced childhood sexual abuse. And this is an ACE or adverse childhood experience that we'll talk about in a little bit. 1 in 3 cis women is a survivor of sexual assault, and then a significant percent of cis women and men, 10 and 4% respectively, experience PTSD. So I'm flagging that these are data for cis folks, not to the exclusion of people who are transgender or gender diverse, but we'll talk more later about how those individuals have even higher prevalence of trauma and PTSD, and that's important to highlight. There are other groups that experience really more than their share disproportionate burdens of trauma that I'd like to highlight for us today. So within the carceral system, 96% of cis women have experienced trauma, which often looks like sexual abuse or intimate partner violence. 93% of moms who are living unhoused have a lifetime history of interpersonal trauma. And then 97% of cis women who are living unhoused and have mental illness have experienced severe physical or sexual abuse. So it's almost universal. And then among cis women who are living unhoused, 87% experience that both as children and then again in adulthood. You can see that for veterans, the majority have experienced trauma, and then again, a high prevalence in people who are in substance use treatment. And I would say, like, just to tag on to that for the substance use treatment, those are people who make it to treatment. So among those who, for whatever barriers, cannot access treatment, I would imagine that it's probably higher. When we think about folks who are transgender or gender diverse, I alluded to their PTSD prevalence being higher, which it absolutely is. So estimates range from 18 to 61%. And then again, comparing that back to the general US population, that's more like 6.8%. In a survey of transgender and gender diverse individuals, the baseline prevalence of PTSD was 42%, and then the prevalence of suicidal ideation was close to 60%. Among those who are endorsing PTSD, the prevalence of suicidal ideation was much higher at almost 88%. So unfortunately, and fortunately, we as clinicians can be sources of harm or of healing for people who are gender diverse. So it's really, an opportunity for us to optimize our environments for folks seeking care. So this is from the 2015 US Transgender Survey report, and the denominator here is individuals who had seen a provider in the last year. So again, I think what we're not seeing is folks who didn't even seek care potentially because of past adverse experiences with the healthcare system. But these are a list of negative experiences that people had, ranging from health provider ignorance about care and having to teach their provider, which happened about to 1 in 4 people, to there were intrusive questions about gender that happened for 15% of people, and then even verbal, physical, or sexual abuse that came up. And about 1 in 3 individuals had at least one of the experiences listed here. So as we think about intersectionality, these data are from the same survey, and we said that 1 in 3 individuals had a negative experience with healthcare providers. But how did race intersect with that experience? And racism, frankly. So you can see that folks who are Native American, the tall bar there, the first blue bar, had a higher 50% chance of having a negative experience with a healthcare provider in the last year, and other folks did as well. So folks who identified as Black, Middle Eastern, or multiracial were more likely than average to have these experiences. So now thinking a little bit about kind of other forms of trauma, systemic trauma, structural racism, we know that the echoes of slavery and more recent policies like redlining have significant health impacts. For example, on breast cancer outcomes, and we'll talk a little bit more about that on the next slide. But we know race itself is a construct, and it's not itself the cause of these inequities that is racism. And the micro and macroaggressions of racism have health impacts both directly and through weathering. So we really need to recognize racism as a form of trauma and work to counteract that. Racial trauma refers to the emotional impacts of stress related to racism, racial discrimination, and race-related stressors, such as being affected by stereotypes, hurtful comments, and barriers to advancement. And people can experience this just like trauma itself that we've talked about more generally, either from having personal experience or having experience to a loved one, a family member, a friend, seeing others mistreated because of their race. So covering events caused by racial discrimination in the media, for example, can also be extremely upsetting, and repeated viewing or frequent media accounts can really amplify those feelings for people. So when we talk about trauma's health impacts, we'll talk too about how the impacts of chronically elevated cortisol can have some intergenerational impacts for people. So Dr. Kim Udall is a colleague and privileged to have here. She and her co-authors review the literature on quantitative exposure to systemic racism and reproductive health outcomes, particularly. And they really identified these 4 domains of systemic racism impacting reproductive health. So civil rights and legal discrimination on the basis of racism, residential segregation, housing discrimination, police violence, and mass incarceration. So to highlight the point, we mentioned redlining. Then redlining has ongoing impacts on people's health. So there was a study looking at mortgage data of about 27,000 women who had an initial diagnosis of stage 1 to 4 breast cancer and then had follow-up that lasted from 6 to 8 years. So overall, 34% of non-Hispanic white participants, 57% of those who identified as Hispanic, and 79% of non-Hispanic Black individuals lived in redline tracts. So already we see profound differences by self-identified race. And then as the redlining index increased for people, they experienced poorer survival outcomes. And this effect was strongest for women who actually had no comorbid conditions. And that was 54% of the sample. So there was an increase in all-cause and breast cancer-specific mortality with increased redlining exposures. And this is something that has not been technically legal for a while, yet continues to have health impacts for our patients. So these are probably things that you see in your office day to day. I can imagine many of you have seen this in patients who do and do not have a flagged diagnosis of trauma or PTSD. So there are some specific associations for prenatal care providers, if any are here, which I think there are based on your M&M. There's a 2-fold increase of low birth weight among people with PTSD prenatally, and then preterm birth is also markedly increased in this group. So we know that when I alluded to intergenerational effects, having sustained activation of the HPA axis in response to chronic stressors can cause neuroendocrine changes, and that can suppress cortisol responses in pregnant people and then in the children of people with PTSD. And that's something that's been seen in survivors of the Holocaust and their descendants. So really, these things have a lot of health impacts for our patients. Now, ACEs are something that I brought up earlier when we were talking a bit about childhood sexual abuse. Are folks able to raise hands if anyone has familiarity with the ACE study? I'll give a pause in case people can. I know a lot of folks are attending virtually. The in-person people, you're kind of blurry on my tiny screen, but I see you. Yep, I see a hand there on my screen. Okay. Couple hands, great. So this was another really massive and groundbreaking study in the 90s where investigators surveyed 17,000 adults about their childhood experiences, health behaviors, and then their current health status. So they looked at the relationship between adverse childhood experiences and those health statuses and behaviors. And ACE scores could range from 0 to 10. So you see in this graph that 0 is that kind of lightest green color in the upper left-hand corner. And then 4 or more is the yellow. So the ACE domains are emotional abuse, physical abuse, sexual abuse, violent treatment of a parental figure, household substance use disorder, household mental illness, parental separation or divorce, household incarceration experience, emotional neglect, and physical neglect. So ACEs are very common. 64% of people in the study had at least one ACE, and then 12.5% or 1 in 8 had 4 or more. And the more ACEs that people reported, the more likely they were to have adverse health outcomes. So ACEs are associated broadly with development of chronic diseases like heart disease, cancer, stroke, diabetes, chronic lung disease, and liver disease. And really, among people who have 6 or more ACEs, so really have a high dose of those on the bottom there, they had a 20-year lower life expectancy than people who had no ACEs at all. So we've talked a little bit about specialty-specific implications of trauma, and then more broadly too, this has life-changing impacts for people. Okay, so I'll stop sharing for a second to take a look at the poll results. But first, since I recognize that a kind of a minority of folks were able to access that poll via WebEx, if you're comfortable putting in the chat, do you feel like you've seen people whose trauma history impacts their clinical outcomes? If you want to drop an A, B, or C in the chat, A, yes, you've seen people for whom you think that's true. B, no, those folks haven't come up for you. Or C, you're not so sure. Feel free to drop that in the chat and I'll give it a minute and then I'll take a look back at the results for folks who did the WebEx earlier, the poll. And thank you for your participation. I'm seeing a lot of A's come in the chat. Okay. Seems like chat's slowing down, so I'm going to stop sharing momentarily and see if I can peek at the poll results. So when folks answered this question, also predominantly people said yes. So there were 16 respondents via the poll mechanism and 14 said yes and 2 said not sure. So people are seeing this and I appreciate that. Okay, so now I'd love to talk a little bit more about like what is trauma-informed care. So that SAMHSA document that I brought out earlier kind of has those 3 E's that are really helpful for thinking about trauma itself. But then here's a set of principles that really can outline trauma-informed care and give us a framework to think about it. So this is care that works to provide safe environments for patients and for staff, for us, create transparency and trustworthiness in relationships, utilizing peer support, encouraging collaboration, offering choices whenever possible, and attending to some of the cultural and historical issues that I've talked about so far. I think that one really key thing here is that we're part of the system. So if we as clinicians and providers don't feel safe and supported in our work, it's really hard for us to provide these qualities of care to patients and to each other as colleagues. We talked about the 3 E's before. SAMHSA also uses four R's to describe trauma-informed care. So realizing the impact of trauma and people's potential for resilience, recognizing how trauma can show up for our patients and also for each other, which is important, responding with practice and policy change, one of the reasons we're here today, and then avoiding re-traumatization for patients and for each other. So there's no quick and easy checklist for this. I am really personally always thinking about opportunities for new ways to incorporate trauma-informed care into my work. So to talk a little bit about some outcomes related to trauma-informed care, the TikTok study was a study where they had primary care that was delivered in environments that kind of had TIC enhancement and focus, and then those that did not. And a significant percentage of the folks in the study were experiencing trafficking. Those who were enrolled at the sites that had more trauma-informed care were much more likely to finish their entire programming and not be involved in trafficking at follow-up compared to those who were kind of experiencing routine primary care. And then the Empower Clinic is in New York City, and there was a great Green Journal article about it a few years back, but it really has wraparound services. They accept referrals from social services organizations and can do exams for people related to getting amnesty, getting their immigration status on the basis of what they've experienced. And a significant percent of their patients have experienced violence and trafficking. So it's just another example of how through providing care that's trauma-informed, we can really make a difference for people in their fuller lives. Okay. So other outcomes that I think are important to share of how trauma-informed care can make a difference. Do folks have familiarity with the JJ Way at all down in Florida? I don't know if that's the case, but something good to look into in your non-existent spare time, I recognize, but This is a midwifery approach to prenatal care created by Jenny Joseph. And I don't know if you'll have a midwifery service on your unit. I know it varies unit to unit, but she's a midwife in Florida. And this, again, utilizes the principles of trauma-informed care. So has peer support components, group-based education, and culturally responsive services to combat disparities in birth outcomes. So here you can see how their multidisciplinary patient-focused approach led to decreases in low birth weight, which is something that we've discussed is associated with prenatal PTSD. Among groups that we're identifying as white, Black, and Hispanic. So just to orient you to this graph, the y-axis is the percentage of folks with low birth weight. Blue is Orange County and red is Florida. And you can see how for all the groups, the first cluster of bars is white, the second Black, and the third Hispanic, that those who were getting care through the JJ Way had significantly lower rates of low birth weight. But I would also flag here that there are still disparities. So people who I self-identified as Black had higher rates of preterm birth still than people who are white or Hispanic. So trauma-informed care helped with improvement, but there are really deep structural barriers and structural racism impacting people's experience of care. And so we really have to continually work to overcome that, and that's a systems problem. Okay, so for the last poll, people, it sounds like overwhelmingly are seeing people that they know have experienced trauma. Do you feel like you're already incorporating some principles of trauma-informed care into your practice? So if you're up for dropping a letter into the chat, if yes, you're feeling pretty sure that that's something you're already doing, which I wouldn't be surprised if you are, that's great. B, not something that's actively going on for you, and then C, you're not sure if that's something you're doing. And I'll give that a minute for folks to respond. I'm loving to see the A's come in here so far. And I'll stop sharing for a moment to take a look over at the prior responses. So among folks who responded via the WebEx poll, there were 16 respondents, 7 said yes, 7 said not sure, and 2 said no. It sounds like for folks currently in the chat that people have more confidence that they're doing trauma-informed care practices. Okay. So I think one area for incorporation, and I would be excited to hear, especially as we get to the end of the talk, or now if people prefer, about how people are already doing some of this work. But as we think about some of the systems that a patient navigates, even before they get to us, because they really experience a world of things before they get into our exam room, for better and for worse. So people might be navigating long phone waits, using the internet, which they do or don't have access to. They may or may not need visibility accommodations and language options. Are people parking? Is there cost to that? Are they taking public transit? Are you in a part of town that's served by public transit or not? Getting work and childcare coverage, insurance issues, other medical complexities that impact their experience of care, mental health differences. And then they get through all of that and they make it into your waiting room. Who is there? What and whom are they encountering in the waiting room in the check-in area? So this can be kind of a daunting mental exercise and feel like a lot of things that are out of our control. But I think it's just really worth emphasizing that by the time a patient gets to us face to face, they have already experienced a lot that might be coloring their impact, their interaction with us. So one first step as you think about this might be doing kind of like a walkthrough of patient and client facing areas in your clinic. So are there ways these spaces can better reflect your patients and their needs, whether it's their appearances, their sizes, their linguistic needs, different levels of COVID caution. I know my institution's about to drop mask requirements Monday. So there are a lot of ways we can try to make spaces more friendly to patients. One thing that we can do in our practices is incorporating screening for trauma. So screening can let patients know that we're aware of the prevalence of trauma and its health impacts. But an important thing to do before we screen is to review the limits of confidentiality. So we're mandatory reporters. So if there's something going on for vulnerable adults or children, or if somebody has threats to others potentially, that those might be things that we might have to report. So letting people know so they know what's going to happen with their disclosure if they choose to disclose anything. And people are understandably reluctant frequently to disclose histories of trauma. So even when they are asked, especially from new providers, they may not prefer to do that. So even if a record has all those things that we talked about before, people are having chronic pelvic pain, or some of those issues, delayed presentation of prenatal care, things like that. If a person's not verbally disclosing, I think treating people kind of with a universal precautions approach with trauma-informed care is great for everybody. And ACOG puts it really nicely in this committee opinion, saying that, quote, not asking about sexual abuse may give tacit support to the survivor's belief that abuse does not matter or does not have medical relevance, and the opportunity for intervention is lost. So there are different ways to screen. You can screen with really kind of broad statements that allow a patient to really interpret in their own way anything that might feel traumatic for them. So, are there any health or life experience that you feel like would impact your experience of care today that you would want me to know about to work well with you in your visit? Super broad. It could be more narrow, asking about childhood sexual abuse. You could say something like, since about 1 in 5 women was sexually abused as a child, I ask all my patients about this experience, about unwanted sexual experiences. And there are other screening modalities. So this is a primary care PTSD. So saying something like, sometimes things happen to people that are really unusually or especially frightening or horrible or traumatic, like a serious accident or fire, physical or sexual assault or abuse, war, seeing somebody be seriously injured or even killed, or having a loved one die through homicide or suicide. So these are target some of those symptoms we talked about earlier with PTSD, as far as hypervigilance, hyperarousal, detachment. And here, 3 out of 5 being positive can be best for sensitivity, and then 4 out of 5 is going to optimize specificity. But depending on your electronic medical record you use, you may be able to kind of pre-assign people a PTSD. And then, as with any screening test, we need to be prepared to act on the answer. And I think for a lot of us, this is a barrier because we think we're opening Pandora's box and what are we going to do with it? So, asking people, we know that survivors want to be asked about their experiences, and you could ask them what they want you to do with that information. For some people, they may just want to disclose. For some people, there are going to be differences about their exam that they might prefer, or other things about their care that they might want documented or not documented. So being clear, if you're putting childhood sexual abuse on the problem list, for example, who's going to see that? How is that going to be reflected in their record? And I think, frequently we have this really great longitudinal relationship with folks receiving prenatal care, and then they go inpatient, and hopefully things translate as far as birth preferences and wishes and all of that care planning. But letting people know to anticipate that can be helpful, so they don't have to rehash everything, but also they don't feel like their business is out there in a way that's uncomfortable for them. Now, when we're thinking about exams specifically, I think a lot of people think about trauma-informed care as applied to exams, and then specifically pelvic exams. So thinking about not having people get undressed prior to speaking with them whenever possible, really asking them at the start, what are their goals for the visit? We know that we tend to interrupt patients within kind of seconds of them starting to talk. And I think all of us have also had that experience of running through our checklist, because especially as trainees, I know we all have it, and we know we're expected to come out with those answers. But then as you put your hand on the door and the patient says, oh, I wanted to talk about. So if we can get that out of the way, and hear what they want to do early on. If it's, 20 things, then what are the things that are really most important for them? How can we satisfy some of their goals during this visit? And if we need follow-up visits, then let's plan on that, but making a plan at the start of the visit so the patient knows what to expect. And then as you're thinking about the exam itself, because you've already done your screening, asking about stuff that might be activating for them, particularly with the exam, or things that would be comforting. What has gone well for them in exams before, and what has not gone well? For some people, I've walked into a room and seen them sitting as far as humanly possible, hunkered down in a corner, and we're not doing that colposcopy today in the office. We are going to the operating room. Just offering those options. Is there a place they can get IV sedation for the IUD insertion or removal, if that is something they need? And then thinking about this, so those nonverbal cues of where are they sitting in the room and how are they looking, and then the space itself. Does it accommodate a chaperone? Do they want one or not? What is your institution's chaperone policy? What is your institution's policy around having support people? I know, COVID has had a lot of impacts on that for all of us, but is that something a patient wants, or do they prefer not to have somebody else in the room? And, are you between them and the door, and how does that feel for them? So all of these things. And I don't know if folks are already aware of Stephanie Tillman, who writes as Feminist Midwife, but she writes really fantastically about consent and ethics of pelvic care. And this is, I think an old tweet of hers, but really thinking about options. So one of the principles we think about with trauma-informed care is offering options throughout the care, and particularly with exams, that can be helpful. So when we think about exams, again, considering the space, I think I was very trained to use kind of the footrests, the clinky, AKA stirrups that kind of flop out from the sides, which I would say that you almost never really need. I still use them for colposcopy because I need that kind of real estate between the feet to be able to move the colposcope. But otherwise, it's another place to offer an option. People can have their feet together or kind of apart with their feet planted, and you can still do almost any procedure you would need to do or aspect of exam you need to do. Having people, asking them to move down, standing to the side, as opposed to having them scoot down towards you as you're seated down, kind of between their legs. And then one thing that I would really encourage people not to do, that I'm sure all of us have seen, is putting any pressure, no matter how light, on the medial aspect of the knees. So whether or not somebody is a survivor, I think that can be just really activating and scary for people. So you could consider saying something like, if you would, like placing your hands lateral to their knees, like I'm doing on the right-hand picture, let your knees fall out to the sides as much as feels comfortable for you. So you're acknowledging somebody's differing mobility, and kind of cueing them that way, as opposed to placing any pressure immediately. And then, thinking about the power of words. So stirrups are for horses, right? So exams, you could say, some people say foot pedals or footrests. And again, like, there's a place for them. Some patients may prefer them, and that's fine. It's a place to offer choice. We have exam tables, other things happen on beds. These tables have drapes, not sheets. So I think just thinking about some of those words, and I think all of us have said things, at times during our training or practice, and cringed or heard other people say kind of cringeworthy things, but it is really worth thinking about the words that we're using and where else patients may have heard them. So things like saying relax. I would consider kind of other ways to cue folks to let their hips be heavy on the table, and things like that, as opposed to relax and it'll be over faster. Other things that people may have heard in really awful circumstances. And then when we're doing all of the best things that we can to try to keep exams safer for people, or just these interactions more generally, whether or not there's exam involved, things can come up. So, there are verbal things that may come up for people, or, audible things. People could cry, they could be visibly upset, their legs could be slamming shut, and things like that. I think all of us have probably experienced that. There can be not audible things. And so, especially if you're seated at somebody's feet doing a pelvic exam, really trying to keep your eyes up for, is somebody kind of checked out? Are they dissociating? They're shutting their eyes, not responding to your questions. They seem like they're not really there. If you have another person, like a chaperone in the room, and they're able to also kind of keep an eye on the patient with you, that can be helpful. But when this comes up for people, we're stopping, whether it's, somebody's legs slamming together and them tensing around a speculum, or just them not being as responsive. Stopping, checking in with them, reminding them where they are, that they're in clinic, calling them by their name, getting them covered, stopping what you're doing. And you can do kind of grounding techniques with them, having them look around the room. Some people will kind of like find the rainbow in the room, looking for something red and orange, and kind of just reorienting themselves, getting them a cool drink of water, but things that take them back to where they are right now, if they've kind of gone somewhere else that they've experienced that's been adverse. And I would say one other thing when we're doing these exams, or procedures, part of my time out for procedures is, at this point, asking people if they want to know more or less about what's going on with their procedure, because for some people they want descriptions, and for some people they want distraction. And whether it's an exam or a procedure, I think, working with continual consent and saying, this is what's next. Is this okay? Next, I would do this. And it may be that you're having a conversation about, especially if you're doing an uncomfortable procedure, how are you going to take good care of yourself later, but then still letting them know how they're progressing through the procedure, if that is what they want to know. And then, after the exam, kind of stepping out for the patient to dress if at all possible. I recognize this sounds like all the time in the world when our clinic schedules are really tight, but it's an opportunity for choice again. Would you want me to step out for a second so you can get dressed, or do you want to kind of talk about findings now? Debriefing for people who have not always had control over their bodies or autonomy. They may feel like their bodies are dirty or flawed in some way. So really reviewing, especially normal findings. And then for stuff that does require follow-up, talking about that. So everybody wants closure and to know what's going on. And I think particularly for folks who have not always felt in control of their bodies, regaining control and having clear expectations about next steps is really critical. And then if we think back a little bit to some of the things we talked about earlier, about people who experience trauma in healthcare, let's think about applying trauma-informed care for people who are gender diverse in our settings. So we know people have experienced maltreatment in our settings. And so just the baseline low-hanging fruit here is to not perpetrate, to not be part of the problem, and then to not tolerate it from others. And I think these things go for racism in medicine also, that calling it out and letting people know that that's not something that is going to be stood for in our clinical spaces. When you see somebody misgendered, or if you misgender somebody or use incorrect pronouns or name yourself, correcting it if somebody else is doing it, if you're doing it yourself, which happens for people, apologizing, moving on, not centering ourselves in that interaction, and just making these things clear in training for everybody who's interacting with patients. So as we said earlier, by the time a patient gets to us, they've experienced a lot of our healthcare system. So really everybody needs training. And for folks who are gender diverse and receiving sexual and reproductive health care, as with anybody, we're talking about sexual health care experiences and asking, for example, about partners, explain why you're asking. So, not making assumptions about people or their partners, how they're sexually active, but asking, for example, if you want STI screening today, I would just like to ask you some questions about how you're active. That could look like, oral or throat screening, vaginal screening, or anal screening, depending on how you're active, and offering those choices for people with an explanation of why. And then mirroring patient language. If somebody's talking about their wife, it's their wife, it's not their girlfriend, their friend. So mirroring their language with respect to their relationships, and then also with body parts. So people may use different language for their anatomy, and asking them about the language they want to use and then reflecting that back is a good part of providing appropriate care for people. So we've talked a bit throughout too about how trauma-informed care is not just for our patients. We too can experience trauma, whether obviously in our own lives, but also related to the healthcare we provide. So we really bear witness to our patients' trauma, and this can have impacts on us and lead to vicarious traumatization, a transformation in our own lives secondary to engaging with patients who deal with trauma. So part of the definition of PTSD, if you recall, is potentially witnessing trauma. So witnessing life-threatening experiences, which when I didn't catch the very start of your M&M, but you're talking about, it sounds like a really intense situation of preterm, twin delivery, and had like split-second decision-making around how are we delivering this second twin. That's a lot, and that's a potential life and death experience or permanent disability experience for that baby, and that carries a lot of weight for the providers involved. So I just want to flag that. So anybody who's experienced an OB-GYN residency, I think because of experiences, whether that or on gyn-onc or other services, we've experienced exposure to actual or threatened death within our practices. So symptoms that folks can have are really similar to PTSD. So maybe intrusive dreams, really strong reactions or feelings, emotional numbing, feeling guilty for one's privilege, feeling unable to talk about or to stop talking about, as I think we and our loved ones have probably experienced about us, some of these experiences, increased absenteeism, problems with boundaries, and lowered self-esteem or a lost sense of competence can come up for people experiencing vicarious traumatization. So really, some of these are personal strategies. Those are things that we might be more individually in control of, like, setting limits and, trying to work on work-life balance. And I want to throw in the asterisk that, like, for the trainees hearing that probably sounds ridiculous because you are asked for 80 hours plus of your life per week. But where you can, I'm hopeful that medicine is changing a bit, because it needs to do better by trainees for sure. And then really institutionally, I think that is the cornerstone of this. So when people have adverse events, is there, a jeopardy schedule? Is there backup for that? What is the access to employee assistance services or other mental health care? And then what are they doing to try to prevent these things? Are they having adequate staffing coverage? Are they talking about stress first aid, and are there people trained in that? Providing opportunities for continuing education in this area, which here we are today. So, certainly we as individuals can do things to try to work on the trauma we may have and prophylax against future things, but it's also on our institutions to help us with that. And then I really like to think about clinician wellness, kind of like the WHO talks about health. So the first principle for the WHO is that health is a state of well-being and not just the absence of disease. So I really think for us, we did not just be not having trauma, but we need to be as well as we can be. The absence of trauma and burnout is not enough. Having personal resilience, which I recognize is getting to be kind of a four-letter word because we're tired of being resilient. We're tired of having to develop grit. And really being professionally fulfilled. And again, this isn't just on individuals. I think our systems owe us systems that are not actively harming us, just at the very least, but really that are helping us flourish. So as we think about some resources, here are some kind of national ones. The AMA has some modules, which are like modules in your non-existent spare time again. ACOG actually has some stuff about adverse events in obstetrics and gynecology. And this QR code is for the physician support line, which I think is great. It's also accessible for medical students. I don't know if there are any in the crowd today, but you could just consider throwing this phone number, the 888-409-0141 in your phone, in case you or someone you know needs it in the future. So just good things to have in your back pocket. And then more locally, I'm grateful to the folks who helped me know about some of these resources that are there for you. So there's, for employees, the EAP, if you don't already have these phone numbers in your phone, I would encourage you to get them. They have the limitation of being like, quote, business hours, where business is like normal people business hours, not us. And of course, emergencies and trauma don't know what time it is. So 3 a.m. is kind of prime time for that stuff. The right-hand QR code is for the Rutgers Wellness website. And then the bottom one is for the Resident Wellness Program. So it can link you to free, confidential, and focused individual, couples, and family counseling, crisis intervention, and prevention-oriented groups and workshops. So I was glad to hear that there are some resources at Rutgers that folks can access. So really for takeaways for all of us, I'm hoping that, we're all together. Trauma is really common. It has a lot of health impacts for people, and we can make adjustments to our practices that are really doable. It sounds like many people are already incorporating trauma-informed care, which is fantastic. I hope that our time together today has given people ideas about how else they might do that. And it looks like we do have some time for questions and conversations. So I would love to hear more about the great things people are already doing. And then you can't leave yourself out of trauma-informed care. So self-care is really crucial, and also looking out for each other, our partners. We're better doctors, partners, and parents when we take the time to process these adverse events that inevitably happen for us in our practices. And you deserve the same trauma-informed care that your patients deserve. Okay. All right, Dr. Baya, I see that you put your hand up. So let me go ahead and mute. I don't know if you just have the superpower to unmute, but I would love to hear what you
Hi,
have to say.
Lauren. I'm here. Thank you so much. That was so wonderful. And it's also so nice to see your face and see all the wonderful things that you've accomplished. So congratulations. We're so happy to have you talk to us. I have just sort of 2 general comments, and I think it's more for the learners that we have in the group. I think one of the things I see a lot, and I'm hoping you can kind of chime in, is that client sometimes, we have to sort of in their body language for not even a good relationship with them. Sometimes that's cue to the fact that they control over something, which is triggering them, or contribute to the fact that they feel like
Dr. Bayat, I'm sorry you're breaking up.
Situations. Oh,
Dr. Owens, did you catch enough of that to respond? I don't know.
I heard you say at the start something about kind of trainees and then talking about body language, but then I kind of lost you a little bit. I'd love to hear what you're trying to say. I'm sorry, I couldn't catch that.
Okay, well, let's move on. We have a resident here in the room who has a question for you.
Sorry, maybe Dr. Bayat can put it in the chat since she was breaking up. But I'm Natalie, one of the residents. I was just wondering, as someone who is practicing in a state that has a lot of abortion protections, just like New Jersey, if you could comment on maybe the trauma that clinicians who are providing abortions in states with restrictions, and also obviously patients who have to travel out of state for abortion care might be experiencing trauma from, the harms of these abortion restrictions, and if there's anything that you have implemented in your practice to kind of address this, both for trainees, clinicians, and patients.
Yeah, what a fantastic question. And I know Dr. Matthews mentioned I had been in Michigan. I mean, I think even though Michigan has ended up like kind of ratifying protections for abortion care in their constitution, I will tell you that being a provider there during the overturn of Roe and not knowing what was going to be legal, having surrounding states basically at one point or another all ban abortion care there was really scary and stressful. And we certainly saw patients from surrounding states coming in. And in Washington State, we see patients from all over coming in. I would say that there's a lot of moral injury that I think all of us have experienced between the COVID pandemic and people's patients' differing appreciations of that, and also between the impacts that intrusions into reproductive health care in the form of abortion care have taken for people. So I think, especially for those of us who are in states where access is relatively preserved and not entirely impinged on, I think being sounding boards and supporting our colleagues in states that are more restricted, however we can, is really important. I'm really heartened to see people who provide abortion care really reaching out to each other and facilitating care in novel ways across state borders, trying to help people's patients access care. And I really think that, the patients are going through so much. I think the fear, some of these laws really enforce themselves through fear. So whether or not somebody's actually going to get in trouble for having an ultrasound in Texas, for example, I had somebody present here who was 31 weeks and had flown from Texas to Washington. And my first thought was, oh my gosh, if you had just had an ultrasound, but like it didn't feel safe to get an ultrasound. That wasn't safe for that person. So I was able to try to like provide referral to other places. We couldn't happen to provide 31-week care where I was at the time, but there are places in the country where somebody can't access that care. I worry that they've probably exhausted the resources they had. We know people who seek later abortion care are more likely to, be living in poverty and have restrictions to their resources. So they so much more need some of like the mutual aid and abortion fund opportunities that exist to help people with care. But yeah, I think acknowledging people, just acknowledging like you have been through a lot to be here. I'm really sorry you had to do that just to access your health care. How can I be helpful for you today? And even if I can't, like that one person that I couldn't be helpful for her, how can I facilitate that care for you? How else can I be helpful with, the limitations we have to our care? And I agree if Dr. Bayet has the ability to throw something in the chat. I don't know if she's driving or otherwise unable, but I would love to hear what she has to say still. And I do see other hands as well.
I see that Dr. Ayers has her hand up.
Good morning. Thank you so much for your talk. It's very, very important. And I think it's something that we are now putting a name to, trauma-informed care. And I think it's important that we also look at systems. One of the things I found very interesting was the information that you had about obstetrical care and its impact to outcomes. For those who have OB emergencies, patients who had like negative outcomes, have there been like actual systematic recommendations for how to address that acutely and chronically? And the second part I was very impressed with is self-care. And has there been things regarding those obstetricians who've been a part of those obstetrical emergencies, and how are they taking care of themselves, or our colleagues identifying that?
Yeah, thank you for those questions, Dr. Ayers. I think that, we know that a significant percent of people who experience birth, even when they do not experience what we would consider an obstetrical emergency, experience their birth as traumatic. So more people than we would expect think back on their birth and find it traumatic. I think that there is a great need for more services around kind of helping people process those births. I don't know that there's, it sounds like your question is, are there like rigorous studies of either like prevalence of that kind of thing or like interventions helping folks who've experienced birth as traumatic? I don't know that there are, but I'm happy to kind of look into that more. I'll make myself a note.
Because
But I
those
think
birth
that,
experiences, the birth trauma, because we deal with birth trauma so much,
Mhm.
those birth
Yeah.
experiences is coming out. There's some people who are doing smaller studies. I was just wondering if you had seen anything else other than that. Those birth experiences, those women, when they are asked, they actually have a lot to say. And I think it's movements in the community more so than actual literature.
I think you're right. I think that, community care is filling in the gaps that we are leaving wide open in people's experience. There is an OB anesthesiologist in Pennsylvania, and I'm having like a moment not remembering her name, but she does a lot around birth trauma and has a special clinic. And she came and did a workshop for us here talking about how people experience these things as really awful. And then for us, we might not realize that. So I think for us as individuals, seeing people at their follow-up, how was that birth for you? And then just listen. Because we read the delivery summary, we read the discharge summary, but that doesn't tell what it was like for the patient or for their partner who might have thought, if you're doing bimanual for retained stuff, they saw something they have never seen with where your hand was for their partner and what the heck just happened. So, yeah. And then for providers, I think there are some smaller studies again on kind of debriefs, structured debriefing in the face of adverse events. But we know that the prevalence of trauma and work-related trauma among people who do labor and delivery, for example, is high. I mean, we see terrible things all the time, and then worse are expected to just go into the next room and deliver babies because it's not that happy. And so I think that there's a real strong need for kind of preventive training. So I was so happy to see that people have gotten some trauma-informed care training within their training, which I feel like I didn't have. But we also need better tools, I think, as providers. And then our systems owe us care after in the wake of these events that will inevitably happen. Dr. Matthews, I see your hand. I don't know if there are other hands.
I'm going to read what Dr. Bayat had wanted to say, but her phone was breaking up. She was talking about when we have non-compliant or difficult patients, that sometimes instead of us getting frustrated with that, getting frustrating with them, sometimes that's our cue to slow down instead and understand what and where this distrust is coming from and how we can earn their trust. And then two, in order for us to be empathetic as providers and show our patients kindness, we need to work within a system that shows us kindness and empathy. So part of the solution needs to be changing our culture when suboptimal outcomes do occur, helping providers instead of shaming them and humiliating them. And she said, for example, like at M&Ms, instead of making people feel, like they're not that what they did was wrong, there's other ways of approaching that situation. And then I guess my question, so that was Dr. Bada, she's still typing, but I'm gonna wrap it for there. And she said something about everyone should watch beloved watch her beloved colleague Dr. Landu, who was lost last year, giving this amazing talk on Amazon, an abortion provider that was lost from New Mexico, giving an amazing talk on Amazon. All right, and then I guess my question is focused around incorporation of resources for patients while in clinic. I understand that we as providers can be great resources, but within the system that we are working in, providers are forced to see more patients than they can give time to each patient. And so has there been any studies looking at the incorporation of having social work constantly in clinic and just someone being there to see the patients instead of waiting to tell the patient someone's going to call you, because sometimes there's a disconnect with the patient not picking up the phone. I myself don't answer numbers I don't know. So I can only imagine that the patients might not answer a number that they don't know. And having someone there that's a social worker that really can provide them with the care that they might need. Is there studies on that or not really?
That's a great question. I don't know if there are. I mean, I think that TikTok study that I referenced had, like real wraparound services, and like the Empower Clinic has like in-person wraparound services. So we know that when those things are present, that is highly beneficial for people. I don't know if there's like the TikTok study had like clinics with and without trauma-informed care principles. I don't know if there is a study evaluating in-house versus like follow-up for like trauma-specific services like social work. That's a huge point that yes, a warm handoff. I don't answer those phone calls either. And like, why would a patient? So, I mean, like, do people answer their phones at all anymore? So how do we think that we're actually doing something for people with that? That's a great point. But yeah, I think those are all good areas to look into. How are we actually serving patients? And Dr. Bayat's comments in the chat are so correct. So, is the patient difficult, or has their life circumstance been difficult? What has made, sorry, I have a small +1. What has made, it is just before 6 a.m. my time, so this is happening. What has made like a home VBAC or a hotel VBAC the safer option than coming in for a trial of labor? There is something that happened in their experience that makes that the most sense for them. And instead of saying, what is going on? What are they thinking? What made that the best reason? And what can we do to earn that trust? Because in many ways and for many reasons, patients have very valid reasons for not trusting our system or us. So I don't take for granted that I am a safe place for a patient. That's something I need to earn.
Dr. Owens, there's a question that I was sent. Are there any systems or programs at your institution or others that you know of for supporting residents in training and addressing their trauma that you have found to be effective or that can be replicated in other programs?
Yeah, so I was a resident at Hopkins, and there was a program called RISE, so Resilience in Stressful Events program, and that was very helpful. So we had, when an adverse event comes up, there are trained folks who will come and do a debrief. I would say it's less resident specific, but it was like extremely helpful. My program director came for a bit and then left. And then, so there were not people in positions of authority in my department there, but there were the multidisciplinary people who were involved in the adverse event, and then people trained to help us talk through it. I think discoverability is potentially a concern for people. Many of us have been named or will be named in suits, and so that I think is another wrinkle. But I think having jeopardy coverage for residents so they can take time off. We had a recent terrible event here, and a resident was able to get kind of coverage for mental health day. We worked to try to offer her partner, who's also a trainee, time off if they wanted it. I think things like that can be really important, because I think one of the insult to injury here is that something terrible happens and you're expected to just keep going, which is inhuman. And if we are asked to do inhuman things, then we are not going to treat people humanely. And I just want to second Dr. Bayat's comment. Dr. Carmen Landau, I saw speak about how to talk to people about kind of discomfort and procedures, and she was a phenomenal abortion care provider and human, and that's just an immense loss all the way around. But watching her speak is transformative, and I would really encourage you to follow that link that Dr. Bayat was so thoughtful to put in the chat.
I think I have one last comment, and my last comment is that if we as providers, our cups are empty, then we cannot give to our patients. So I like that you address provider centered, kind of like making sure that you're okay. And even before you started your grand rounds this morning, you're like, if you need to, turn your camera off, whatever. I love that. So thank you very much for addressing that, because I feel like as providers, we always feel like we just always have to pour. And sometimes our cup is like this much full. And if we don't have this much, that's when then we start to think that, oh, the patient is not compliant. And we start to put all these things in our head because we don't have enough inside of us to continue going. So always remembering to really center ourselves and really focus on ourselves too, as we are continuing to provide this important work.
Yeah, thank you for that. I really agree. And if having those feelings of burnout, of lack of empathy, we know empathy decreases across medical training. That's not a problem with us. That's not us being bad people. That's us being asked to do impossible things and experiencing lots of our own and others' trauma. And so it's okay to need that time, and our systems really need to make allowance for that. I agree with you.
All right, well, Dr. Owens, thank you very much for this excellent talk. I think we're going to have to leave it there because we're just about out of time.
Yeah, thank you so much for having me. I'm grateful for your time and attention and happy to hear from anybody and follow up. Thanks for your excellent questions and engagement.
Thank you. All right. Well, I hope everyone has a successful and fulfilling day. Thank you.
Thanks.